Good afternoon, ladies and gentlemen. I'm Dr. Niroshan Lakunarangoda. On behalf of Ceylon College of Physicians, I warmly welcome you to the fourth lecture on cutting-edge lecture series with international faculty. May I invite the President of Ceylon College of Physicians, Professor Arosha Disanayaka, to speak a few words. Over to you, sir.
Thank you, Niroshan. A warm welcome to our guest speaker this morning here and afternoon for Professor Ma, Professor Henry Ma, who is joining us from Australia. A warm welcome to you as well as all in the audience. This is the fourth in our series of peer learning cutting edge lecture series. As we've discussed before, we are learning from our peers as well as from overseas faculty. And with the overseas faculty, we are trying to cover some advancing area or new area in medicine where we can actually improve or enhance our practice, take it one step forward. And it is a great pleasure that we have an eminent expert on neurology speaking to us this morning. So I hope all of you will benefit from this and then hope that you will join for our next in the series of cutting edge lecture series as well. Right, I will hand over to my colleague, former past president of the CCP, Professor Uday Ranawaka, who has been very kind in arranging this guest lecture by liaising with Professor Ma. Over to Professor Uday Ranawaka to introduce today's speaker.
Yes, thank you, Arosha. It is my great pleasure to introduce Professor Henry Ma. Professor Ma is the Director of Neurology and Stroke at the Monash Health and is the Professor of Medicine at the School of Clinical Sciences, Department of Medicine in the Monash University. He's a brilliant researcher and an academic, and his main interest is in the imaging of the ischemic penumbra, and his work, his pivotal work has transformed the way we look at this ischemic penumbra and has been the basis of some of the most recent clinical trials on stroke and acute stroke treatment and imaging, especially the extent trials. And Professor Ma has been instrumental in setting up the Australasian Stroke Academy and is keen on developing the stroke training for all levels of health professionals and stroke physicians. And importantly, Professor Ma is a friend of this country, and I'm very happy to have him here, especially just not even a day after we have just thrashed them in cricket yesterday in the one-day series. And he has been here before to the Association of Sri Lanka Neurologists annual meeting in 2017. So this is a joint session between the Ceylon College of Physicians and the Association of Sri Lankan Neurologists. So, and I'm sure Henry would be delighted to come back here whenever the travel restrictions and the other problems that we are facing right now ease off and things get better. Without much ado, over to Professor Henry Ma to talk to us about the more recent advances in the acute ischemic stroke imaging and treatment. Over to you, Henry.
Thank you, President and Professor Ranawaka. Thanks for your kind invitation and warm welcome. Yes, I'm very much of a friend of Sri Lanka. I'd love to come back one day. Can I share my screen? So everyone can see my screen. Can someone tell me it's okay? Good, excellent. So thanks for the invitations. My topic today is recent advances in acute stroke management. This is ischemic stroke. I have no conflict of interest to declare. This is a big topic. So I'm going to run through quite a number of areas of particularly recent advances. And in fact, I will keep referring back to this pathway of patient care. As you can see, initially there is a patient having ischemic stroke. Then will be either pick up a mobile stroke unit or ambulance, or they come to the hospital. They either go to a primary local hospital, or they may go to a comprehensive stroke center with thrombectomy available, then obviously they will go through advanced neuroimaging or local imaging, and they either eligible for thrombolysis or thrombectomy or both. I will go through each individually. So let's go through mobile stroke unit first. This is a very hot topic at the moment. Mobile stroke unit, we have one in Melbourne and getting second one in around my hospital in Melbourne now. So we'll get one next year. Basically, it's a stroke ambulance with a CT scanner, usually a neurologist, a stroke nurse, and radiographer. They can actually image the patient in the truck, and you can identify intracranial hemorrhage, last vessel occlusion, or infarct. And our idea is we can provide thrombolysis early in the ambulance. This is just published recently in September 2021. This American study looked at stroke onset within 4.5 hours and comparing mobile stroke unit and emergency medical care. The primary outcome is excellent functional outcome at 3 months. And very interestingly, the mobile stroke performed extremely well. It's a 55% versus 44% of primary outcome. And so it's actually improved 3 months function. As expected, you would expect the median time of onset to thrombolysis would be a lot quicker in the ambulance. But interestingly, the time through thrombectomy was not any difference between the mobile stroke unit or EMS. But despite that, there was a significant difference in functional outcome. So there is a other just published this year in comparing mobile stroke unit with usual care, a meta-analysis. Again, that shows, as you can see, a net benefit of functional outcome for mobile stroke unit of excellent functional outcome MRS 0 to 1, with odds ratio 1.64. It actually reduced disability over the whole range of MRS, including good outcome MRS 0 to 2. Again, as expected, you had shorter time window to thrombolysis. You got more patients had thrombolysis within golden hours, and onset of thrombolysis was shorter. There's no difference in death or symptomatic hemorrhage. This just hot off the press. So therefore, the conclusion is, so every city, if possible, should have a mobile stroke unit because it's actually improved functional outcome. So let's move on to the next step, which is thrombolysis here. I will go back to each one individually. So I don't have to go through this again. Back in NINDs in 1995 and ECAS-2 in 2008, both established the benefit of thrombolysis up to 4.5 hours of stroke onset. And that's why we've been using thrombolysis all along for ischemic stroke. As you can see, using non-contrast CT scanner, the benefit reduces over time. It in fact crossed over net benefit at about 6 hours. So therefore, we shouldn't really be able to extend the thrombolysis time beyond 6 hours. But I hinted the fact that that was using non-contrast CT for patient selection. So therefore, to go beyond that time window, we need to have an enriched cohort by advanced neuroimaging. So therefore, now we go on to advanced neuroimaging with thrombolysis. There are two methods for advanced neuroimaging. I'll go through them a little bit in detail, but really important to understand which is applicable for what time window. The first one is perfusion imaging, which you look at the blood flow through the blood vessel, usually the middle cerebral artery in the brain, as you can see, indicated by the green area where there is a perfusion deficit, lack of blood flow, and the red area meaning there's a dead infarct tissue. And you can see there is a substantial mismatch here for this patient. But for this patient, there's much less mismatch. In most of the penumbra is in fact infarcted. And that's what we call CD perfusion. The other method to select patient is using DWI flare mismatch. So as we all know, the usual thinking is that DWI means infarct tissue, but some of them may not infarct. As you can see in this patient, there's a DWI lesion, but not on the flare. If it's on the flare, it means it's infarcted. And similarly in this patient, there is DWI and flare mismatch. However, on the other hand, this patient, there is a DWI lesion, but also a matching lesion, same here. So this meaning that there's a potentially salvageable tissue, while this doesn't. So these are the two advanced neuroimaging methods to be used for patient selection. So I myself used perfusion imaging and performed the EXTEND trial, was published back in 2019, and look at patients from 4.5 to 9 hours of stroke onset and also wake up stroke. And as I mentioned before, we use perfusion imaging with specific numbers of perfusion lesions and ischemic core. We don't want a large core, but we want a big perfusion mismatch. So it's important to also understand we also had wake-up stroke patient within the EXTEND cohort, which would calculate from the midpoint of going to sleep and waking up at 9 hours. So there's a specific calculation method for the wake-up stroke. And as people have known, the result was positive. It proved that thrombolysis in this cohort of a patient of 4.5 to 9 hours and wake-up stroke benefit from thrombolysis over placebo with 3 months excellent functional outcome. And then we pulled a patient together from the ECAS4 trial, which is an EXTEND version in Europe, and the older EPITHET trial, which is also extended time window. And not surprisingly, the result showed 29% of excellent functional outcome favoring thrombolysis. So that firmly established CT perfusion used in this cohort of patient could extend the time window to achieve better functional outcome. So let's look at the other method. I talked about perfusion method. Let's look at the DWI flare mismatch method. This was employed by the German group, Gritz-Kamala, to perform the wake-up trial. So this is, I mentioned, using DWI flare mismatch. The criteria is quite different to EXTEND. These are the patients with unknown time of stroke onset, meaning that, and then they had their TPA or the treatment within 4.5 hours of symptoms identified. So not a clear-cut known time of onset as in EXTEND. And this group of patients had a lower median NIHSS, so the milder group of patients. But again, it shows a benefit of alteplase compared to placebo for this group of patients with a known time of onset with favorable outcome, favoring alteplase. So the two group of us got together, where we had this EOS collaboration, including EXTEND, Wake Up, ECAS4, Thoughts, which is the Japanese version of Wake Up, and Mr. Witness from America. So we put all these patients together, looking at the benefit of alteplase in patients with unknown time of stroke onset. And not surprisingly, again, that the alteplase performs more favorable than the placebo, showing that alteplase improved 3 months outcome in all this trial in patients with unknown time of onset. So this has led to the change of guidelines. This is the European Stroke Organization guideline. On the bottom and the top is Australian guideline. The Australian guideline suggests that patient who meets perfusion mismatch criteria using CT perfusion, intravenous alteplase should be administered up to 9 hours after the time the patient was last known well, or from the midpoint of sleep for a patient who wake up with stroke. This is exactly the EXTEND criteria. The European Stroke Guideline also shows strong recommendations for patients with ischemic stroke of 4.5 to 9 hours duration with known time of onset and a CT or MRI mismatched, for whom mechanical thrombectomy is either not indicated or not planned, and it's recommended. And on the other hand, it's also for patients with ischemic stroke on awakening from sleep who are last seen well more than 4.5 hours or earlier, using DWI flare mismatch, which I mentioned earlier, also suggests for whom mechanical thrombectomy is either not indicated or planned, suggesting thrombolysis. So both Wake Up and EXTEND have changed the guidelines in Australia and Europe. So now I talked about thrombectomy. You cannot talk about thrombectomy without talking about advanced neuroimaging too. But the advanced imaging will utilize the same method as CD perfusion. So by 2015, there were 5 landmark trials showing endovascular clot retrieval or thrombectomy. It's much better performance than thrombolysis for good functional outcome in patients with large vessel occlusion up to 6 hours. So I'm not going to go through that. But more important thing is that what I put an arrow here. If you look at the trial, Mr. Clean, Replicat, Escape, SWIP Prime, Extend IA, it's mainly this one that actually use advanced neuroimaging for selection. And you can see that there is a potentially better benefit, meaning potentially advanced neuroimaging select better patient for thrombectomy. And indeed, if you look at Extend IA and SWIP Prime, the actual treatment effect is actually much larger than the one did not use. So suggesting that, again, similar to thrombolysis, to extend the thrombectomy time window, you again have to select the right patients using advanced neuroimaging. And the HERMES studies is actually pooling all this data together and looking at who are the patients that benefits. And interesting, if you look at forest plot, patients with very big infarct, such as aspects of 0.5 cross the midline, and patient who had M2 or distal clots also cross the midline too. Patient of mild stroke also cross the midline. Overall, thrombectomy is definitely beneficial. It favors intervention over control, but these are the ones that may still have the question mark. So what are the factors affecting thrombectomy outcome? Overall, the 2 main ones, age and NIHSS. The older age, the more severe the stroke, the less likely you're going to have a great outcome. So as I mentioned, those trials were up to 6 hours from stroke onset. Dawn and Diffuse 3 again extended the thrombectomy time window. Dawn up to 24 hours and Diffuse 3 up to 16 hours. Dawn used a clinical imaging mismatch or core clinical mismatch here, while Diffuse 3 used perfusion mismatch. And both shows thrombectomy superior to medical therapy for patients with large vessel occlusion and with perfusion mismatch. And this is looking at patients with mismatch or no mismatch and different time cohort. So using CT perfusion to predict. So these are the patients less than 6 hours. These are patients more than 6 hours. Patients who get reperfusion with a target mismatch gets a lot better in both time window. So patient with target mismatch and you reperfuse them, they perform a lot better, even up to 16 hours, as shown. However, this is not the end of the story for imaging for thrombectomy. Collateral circulation is found to be very important. As you can see from here, collateral circulations where there's a large vessel occlusion here, then you can see the collateral circulation coming in, while this is less, and there is basically none collateral circulation for the poor, intermediate, and good. And we do think that collateral circulation helps to sustain the penumbra, and so that we can have more time to salvage it. So this is suggested by Professor Greg Albert, where if you look at the clinical trial, Mr. Clean, Extend IA, SWIP Prime, and Dawn Diffuse. You know, Dawn Diffuse, their patient way up the end here, and the core is very small. While Mr. Clean and really them hyperacute patients and with larger core. So probably these are what we call the rapid progressor with poor collateral. And the Diffuse 3 and Dawn, with using perfusion imaging, was able to select patients who have good collateral circulation with a small core and a large perfusion deficit. And indeed, if you look at collateral circulation and thrombectomy outcome, if you have no collateral circulation, TPA and thrombectomy, thrombectomy still do better, But as you go on with the good and excellent collateral circulation, the benefit of thrombectomy is even more. So the collateral circulation helps to sustain the penumbra and reduce the core infarct size until you achieve reperfusion by thrombectomy. Obviously, the best thrombectomy result is with small core, excellent collateral, and earlier time. Having good collateral doesn't mean you've got time. You still have to go in and save the brain as soon as possible. It just means that it can sustain the penumbra longer from turning into infarct core. So if you look at this diagram here, in all patients, as time went on, the good outcome reduces. In patients with good target mismatch, meaning possible good collateral circulation, despite time, the good outcome after thrombectomy still remains. But in patients with very bad collateral circulations, with time, the good outcome lost very quickly. So that's again, tell us how important collateral circulation is. So now, this is probably the last slides on this. It's now, Aurora is a trial just published this year, putting all the thrombectomy trials together and looking at all the subgroups. As you can see, overall, there is a substantial benefit from thrombectomy compared to control group. And 6 to 12 hours, 12 to 24 hours, virtually there's no difference. The benefit still remains. And from the forest plot, you can see it benefits in a lot of subpopulations. And so therefore, it is actually beneficial in a lot of patients up to 24 hours. And that's the strength of the Aurora systematic meta-analysis. So basically, from thrombectomy perspective, up to 24 hours and using advanced imaging, identify patient is important. Oops. So let's talk about tenecteplase thrombolysis. So tenecteplase is a genetic engineered TPA mutant, and it has actually a bit of a longer half-life than TPA, and it has higher fibrin specificity and plasma and fibrinogen conversions. It's also more resistant to PA1. So the first signal about tenecteplase benefit came in 2012. It's from Professor Mark Parsons. It's basically a phase 2 trial looking at tenecteplase versus TPA, and it showed tenecteplase had much better reperfusion rate and in fact improved clinical outcome. That was quite surprising because that was meant to be a phase 2 trial. We probably won't go through that. But however, the subsequent trials, such as a test, which was another phase 2 trial, which performed in stroke patient within 4.5 hours using CD perfusion selection, but unfortunately, it was not significant difference between tenecteplase and alteplase. This group of patients did have quite significant large vessel occlusions. And then the other tenecteplase trial was NOR-TEST. This is the first NOR-TEST of phase 3 trial using a higher dose of 0.4 milligram per kilogram of tenecteplase. Again, it did not show any outcome. The importance about NOR-TEST is it's actually quite mild stroke patients. They only have NRHS is about 5.6, 5.8, and very low large vessel occlusions. So this is a very mild cohort of stroke patients. And there was no difference in primary outcome. But how about TNK before thrombectomy? We use TPA before thrombectomy. What about if we use TNK before? So we performed the Extend TNK in Australia. I was part of this trial and looking at 0.25 milligram per kilogram of tenecteplase versus TPA. And it was surprisingly positive. The primary endpoint was reperfusion and was far superior of 22% versus 10% with a P0.03. But in fact, the median MRS at 90 days was surprising to us, actually improved. So tenecteplase has not just a better reperfusion rate, but better functional outcome in patients used before thrombectomy. So we did the second part of Extend TNK, basically looking at the two doses, 0.25 versus 0.4. Overall, there was no difference between the two doses. Well, let's put the TNK trials together and see what we get. So this study in 2019, looking at 5 different TNK trials, 2 of them NOR-TEST, extended IATNK, both allow thrombectomy. So if you look at it, it may the 0.25 milligram per kilogram dose has the benefit over TPA compared to the 0.4. This is a non-inferiority trial. So they set 4 margins, 6.5%, 4%, and 1.5% non-inferiority margins. So it did show the 0.25 was non-inferior at the 6.5% compared to delta plates. And overall, at 3 months MRI, it does seem like tenecteplase has a benefit over alteplase, and there was no difference in intracranial hemorrhage. But that was 2019. So let's look at the trials of tenecteplase in patients only with large vessel occlusion. The one before I showed with 5 was a mixed group. This is only looking at patients who had tenecteplase with large vessel occlusion. As you can see on the forest plot, there is a much significant benefit of TNK over favoring TNK over TPA. And MRI still to 2 with canalization and functional outcome. It's actually twofold of good clinical outcome compared to TPA. So this is in patient with large vessel occlusion. And if you look at the ESO guidelines, what it's based on for the TNK recommendations, the one that really positive in the forest plot is the pool analysis of patient with LVO, large vessel occlusion, but not in selected patients and not in all patients. So we actually performed another test called TASE-8, which just got published in Lancet Neurology. We combined tenecteplase in the stroke ambulance. So in the stroke ambulance, we performed tenecteplase versus TPA and look at the outcome. The primary outcome is reperfusion, is the perfusion volume, meaning the per number volume arriving at hospital. The median perfusion volume is 12 versus 35%. So tenecteplase actually reperfused more so than alteplase, and that was statistically significant, but we could not find any functional improvement. But it did show that was significantly better in reperfusion. So if you look at 2019, I'm reminding you of 2019 of the guideline from the AHA, the American guideline. It says it may be reasonable to choose tenecteplase 0.25 over IVT alteplase in patients without contraindications and eligible to go for thrombectomy. So these are LVO patients. And tenecteplase at 0.4 milligram has not been proven to be superior or non-inferior to alteplase, but may be considered as an alternative in patients with minor neurological impairment. Now, this is 2019. And similarly in Australia, we also have a similar recommendation. We have a strong recommendation for tenecteplase for patients with large vessel occlusion using 0.25 milligram per kilogram here, but a weak recommendation for patients whom disabling ischemic stroke without large vessel occlusion, tenecteplase may be used as an alternative to alteplase. And similar, but in European guideline, it's a bit different. In European guideline, it's a bit more up to date. It was more published last year, 2021. They recommend that patients who have ischemic stroke less than 4.5 hours, not eligible for thrombectomy, not for LVO, not with LVO. We suggest intravenous thrombolysis with alteplase over tenecteplase. The recommendation is for patients with less than 4.5 hours with large vessel occlusion, candidate for thrombectomy, and intravenous thrombolysis. We suggest IV tenecteplase. So they suggest tenecteplase for patients with LVO. Because if you look at the latest publication of NORTEST 2, part 2, which is a phase 3 trial looking at 0.4 milligram per kilogram tenecteplase compared to TPA within 4.5 hours stroke onset, this was not non-inferior. In fact, you can see tenecteplase worse than alteplase. But what more concerning is the intracranial hemorrhage, with 21% versus 7%, which is statistically significant. So not just this was non-inferior, but there was an increase of intracranial hemorrhage with tenecteplase. There's a second part of NORTEST 2 ongoing, I think using 0.25 milligrams per kilogram. And also in Australia, we have TASE ongoing, randomizing patients again, comparing tenecteplase alteplase, which is led by Mark Parsons. And so what's the future for thrombolysis and thrombectomy right now is that we are looking at up to 24 hours of stroke, comparing best medical therapy and tenecteplase in patients with large vessel occlusion. So we call it eternal. So let's look at other therapy, such as bridging therapy or direct thrombectomy. What I mean by that is, at the moment, all the clinical trials have been proven have been using thrombolysis before thrombectomy. But what about skipping thrombolysis and just go directly go to thrombectomy and forget about thrombolysis? Why? Why direct thrombectomy? Well, because there is a risk of potential distal migration, meaning that if you give thrombolysis, you may break down the clot from the ICA or M1, and it goes to M3 and M4, where your stent could not go in that clot retrieve and make things worse. And also, there is a risk of hemorrhage with thrombolysis. And also setting up thrombolysis may cause time delay. But what's the benefit of potential bridging therapy? Because we think that TPA can help with canalization, we do know that. May also affect microcirculations with perfusion. And all thrombectomy trials have used bridging therapy. And also, it's really important when you transfer a patient from a primary stroke center to a comprehensive stroke center, you want to give them a chance to recanalize and reperfuse en route to the comprehensive stroke center by thrombolizing them. Now, there are quite a number of trials I mentioned here: direct, DVT, skip, direct safe, strip prime, misicline, IV. I won't go through individually each one of them in detail, but I will go through them in one slide. This is all about what we call non-inferiority. All these trials look at comparing direct thrombectomy being non-inferior to bridging therapy. Now, if people understand the non-inferiority statistic, it's all about where you put the threshold or where your cutoff is being non-inferior or not non-inferior. And there's no clear margin. So if you set it very leniently, you'll easily get non-inferiority. If you're very, very strict, it's very hard to prove non-inferior. So let's go through each one of them. Direct MT was an Asian study, less than 4.5 hours. It was proven non-inferior. But even though you look at MRI 0-2, it's 36.4 versus 36.8%. They set the lower margin of 0.8. If you look at the DEVT, less than 4 hours, the non-inferior margin is actually 10%. Again, it proved that direct thrombectomy was non-inferior, but non-superior. The Japanese trial SKIP set the margin of non-inferiority of 0.74. It was not non-inferior for direct thrombectomy. Then you look at Mr. Clino IV. It's actually test for superiority. And it was 51% versus 49%, but was not reached statistical significance, so superiority was not demonstrated. If you look at SWIFT direct, the non-inferiority margin set at 12%. And the functional outcome was 65% versus 57%. Again, it did not demonstrate non-inferiority. The last one is direct safe, which I was involved in Australia. That's an Australian study. The MRS outcome was 60 versus 54%. The non-inferiority margin was set at 10%, and again, non-inferiority was not reached. So you can see there is a mixed result. Depends on where the trial set the non-inferiority margin. There were some non-inferior ones, there are some not non-inferior ones. So therefore, we are waiting for bigger individual patient data pool analysis, which hopefully coming soon. So let's look at another one, direct and skip. What I mean by that is there are patients may get to the local stroke center which cannot perform thrombectomy, then you may thrombolize the patient and directly go to comprehensive stroke center, or you go directly to comprehensive stroke center. So there is a questions about which one is better. This is RACECAT trial was a Spanish trial just published this year, looking at direct to thrombectomy cable center versus going to a primary stroke center and transfer. Interestingly, within that area in Spain, they could not show any significant difference outcome. It's a pretty crude MRS of 3 of both outcome similarly. And there was no mortality difference. But I think we need more validation data from different regions around the world. But that's an interesting outcome here. So let's look at further details on thrombectomy and thrombolysis. So what I mentioned before were all anterior circulation study. That's what about basilar arterial occlusion, which is really terrible disease to have. This is the best study published in 2020. It's a Chinese study with severe basilar stroke. Overall, it did not show any outcome different compared to thrombectomy versus best medical therapy with similar rate of hemorrhage, which was rather surprising. And then the basic study published next year in New England Journal of Medicine, looking at vertebral and basilar arterial occlusion, and 98 patients screened but went on to thrombectomy. There's a bit of a crossover. Overall, there was no difference between thrombectomy and best medical care in vertebral and basilar arterial occlusion, which is quite disappointing. As you can see, these whole patients are very severe with median NIHSS of 21, and the favorable outcome was not reached. And then you look at tenecteplase in posterior circulation using extended IA data and Batman data. It seems like TNK has better reperfusion, not functional outcome, reperfusion compared to alteplase in posterior circulation for tenecteplase. This is an update. Just recently from a European Stroke Conference in May. This is a Chinese study presented. I don't have the full data. It's basilar arterial occlusion thrombectomy versus the best medical therapy within 6 to 24 hours. It was terminated early because the primary outcome was reached of MRCL-3 of 46% versus 24% favoring thrombectomy. So thrombectomy is superior to medical therapy for basilar arterial occlusion. And we're waiting for publications. And attention was also announced at the ESOC, similarly to basilar arterial occlusion up to 12 hours. Primary outcome was MRCL-3 of 46 versus 23%. Again, thrombectomy is superior to medical therapy for posterior circulation stroke. I'm very happy to see that. What about mild strokes? Does thrombectomy help? So this is a medical therapy versus mechanical thrombectomy for mild stroke. It's an international multi-center analysis and meta-analysis. Overall, it didn't look like there was much difference. The median NIH was very mild at only 4, and both look at very good collateral circulations. It seems to have a bit more hemorrhage in the thrombectomy group. So if you look at they all got very good collateral circulation, same the pronoun, but there's no wonder they have good outcome. They also have proximal occlusion and successful reperfusion. And so discharge NIH is pretty much no different. I mean, it was 0.02 with the NIHSS of 2 versus 1. So this is another study looking at bridging therapy of IV thrombolysis in minor stroke with large vessel occlusion. What this study basic observational is an observational study shows that the large vessel occlusion is better off with bridging therapy. In fact, the more distal you go, the more favor thrombolysis. Or you go, the more proximal occlusion you go, the more likely you need bridging therapy to achieve good outcome, meaning thrombectomy. So location is really important for minor stroke. So this is a very interesting study published just last year, looking at if you have a patient have minor stroke, but with a large vessel occlusion, what are the risk factors for this patient that's going to deteriorate, meaning early neurological deterioration? They have found this patient, if you have no early neurological deterioration, you do a lot better than a patient have early neurological deterioration. And if you perform rescue thrombectomy, they actually do better in this patient who had early deterioration. What are the important factors that that's associated with early deterioration? One is thrombus length, more than 9 millimeters, a very long thrombus on the scan. Or the patient have a very proximal occlusion, such as ICA, M1, and you go down to M2, it didn't really matter. So the location and the clot length is really important to predict who are the patients who have minor stroke is going to deteriorate with large vessel occlusion. So what about some adjuvant therapy during thrombectomy? So this is a study looking at once you've done the clot retrieval, successful reperfusion, they inject thrombolysis alteplase to hopefully help the microcirculation improvement and to see if it actually associated with better outcome. Interestingly, this study did show at 3 months, it's 59% versus 40% favoring the intraarterial alteplase. It may be because it helped microcirculation reperfusion by injecting alteplase after successful thrombectomy. So it's an interesting study. As you can see, intraarterial alteplase have better functional outcome compared to the placebo. But there's no difference in hemorrhage. But what about if you actually give aspirin or heparin during thrombectomy? Does it help to clean up clots and things? No, it doesn't. In this study, looking at aspirin on a fraction of heparin during thrombectomy, within 6 hours stroke onset, there's no difference in functional outcome between the two groups. But as we would expect, aspirin versus no aspirin, aspirin at a higher bleeding rate, and same with heparin, with no benefit in functional outcome. What about neuroprotection? People may have known this, STEP NA1 was the first study and we're using narinotide within 12 hours stroke onset in patients with moderately good collateral circulation. And for thrombectomy, imaging using multi-phase CTA, NA1 versus placebo in patients with thrombectomy plus or minus TPA. The primary outcome is MRI 0-2, which is good functional outcome. Unfortunately, overall, the study was negative. These are the patients with moderate severe stroke, NIHSS of 17 with excellent collateral circulation. But unfortunately, the narinotide versus placebo was no different. But if you look at the subgroup who did not have alteplase, there seems to be benefit for narinotide compared to placebo, compared to the patient who actually had alteplase. Narinotide didn't seem to affect. What does that mean is that if you look at narinotide in the patient who had no TPA group, there's probably a functional benefit. This may be because the narinotide amino acid sequence is split by the plasmid. So therefore, the TPA may have caused a subtherapeutic level of narinotide, causing it maybe not working. So now there is a new study called Escape Next, which is looking at patients who did not have TPA. So in summary, thrombolysis. TPA is a standard up to 9 hours from stroke onset and in wake-up stroke. All the required advanced neuroimaging, such as CT perfusion or MRI detected by flare mismatch. Tenecteplase. It seems to be effective before thrombectomy in patients with large vessel occlusion, especially with better reperfusion result. We do await for more trial data. What about thrombectomy? It should be done with up to 24 hours of stroke onset, both anterior and posterior circulation. It requires advanced neuroimaging. Collateral circulation is really important. And there is more and more trial looking into incorporating collateral circulation score in patient selection. But there are questions still remain. What's the best way to treat mild stroke patients? Which one is better, direct thrombectomy or bridging with TPA and thrombectomy? We're waiting for more data. What are our patients with distal vessel occlusion? There's solid data for patients with ICA, M1, proximal M2, or even mid M2. But what are distal M2 and all that? We need further trial. And then what about the data of direct thrombectomy capable center versus local stroke center and drip and ship? And also the future of neuroprotection. So thank you for inviting me, and I hope you enjoyed my lecture.
Thank you very much indeed, Professor Henry Ma, for that excellent talk in acute ischemic stroke care. So we've got some time to take up a few questions. Now, let me ask now, what is the best neuroimaging in an ideal setting that you would recommend for a patient presenting with an acute stroke?
Yes, I like the word ideal. ideal situation would be CT perfusion, CT angiogram, and post-contrast CT. Why would I suggest that? Number one, CT angiogram, you will pick up the large vessel occlusion, plus also tell you the collateral circulation score. Then you know that if someone, for argument's sake, need to transfer from a primary center to a comprehensive center, and you got very poor collateral circulation, you probably call a helicopter or a plane, not a roll car, because you know that this patient is a rapid progressor. Secondly, CT perfusion is used both in diffuse 3 extend to select patient with extended thrombolysis time window. So that's important for those implementation. Why post-contrast CT? I always do that is because if you've got contrast leak, it indicates potential infarct tissue too. So I think that ideally it will be at least CTA and CTP for advanced imaging.
Yeah, thank you. So do you practice tenecteplase in your center at the moment?
At the moment, we are recruiting tenecteplase into trials at the moment.
Okay, at the trial stage.
At the trial, because we're recruiting in the trials, because I think we still need to prove tenecteplase what cohort of patient. I think tenecteplase for large vessel occlusion is quite clear. If patient large vessel occlusion, I think tenecteplase can help too. But we are recruiting in trials. And at one stage, I must say, during COVID, when alteplase was not quite available, we were actually thinking about using tenecteplase too. So at the moment, we are recruiting in the tenecteplase trial.
Can I, Kumarangi, can I ask a question?
Yes.
Yes, thank you for that excellent talk, which is really an eye-opener for the practicing clinicians in this country. So one question, Henry, is that we are also seriously thinking of using tenecteplase instead of alteplase here with the possible cost effectiveness also keeping that in mind. Now it seems from the data that tenecteplase seems to work better for the large vessel occlusions than for small vessel occlusions. Whereas we know that the alteplase data has shown us that it is not effective for large vessel occlusions. Why do you think, is there any scientific basis for that difference?
I can only postulate, I'm not a bench scientist. Thank you for the excellent question. It looks at all the data, you're absolutely right. It looks at it pretty much effective in large vessel occlusion. Maybe because the fibrin adherence and specificity adhere to larger clots, more so than alteplase. That's why it's more effective in larger clots than probably microclots, which are more probably platelet-based rather than fibrin-based. So I wonder that may be why tenecteplase perform better. And in terms of the non-large vessel occlusion, I think we have to wait for the data because the NORTEST Part A was quite a bit of surprising results because probably using a 0.4 milligram. So we wait for the Part B and TASTE to tell us in a whole cohort how does tenecteplase perform. But I think for LVO, it's very clear. I suspect it's because of fibrin specificity, that's why it's better off a large clot.
Okay.
Thank you, Professor Ma. So we have just a few more questions. Now, are stat doses of antiplatelets indicated before thrombolysis in acute ischemic stroke care?
Say again. Sorry.
Stat doses of antiplatelets, that is 300 milligram of aspirin, clopidogrel. Do you recommend those prior to thrombolysis?
No. There is no evidence to suggest that. Basically, if you look at all the trials, the trials for thrombolysis and thrombectomy, they basically just alteplase and thrombectomy or without thrombectomy. There is no antiplatelet thing. Right. But obviously, patient could come in taking antiplatelet, but that wouldn't necessarily affect it. But you won't give extra antiplatelet for that. And in fact, if you actually look at the IV aspirin trial during thrombectomy, it made no benefit, but actually caused more bleeding.
Are there any trials which have shown effectiveness of TPA in large vessel occlusion?
If you actually look at the extent data by itself, TPA actually recanalize, I didn't present that data, it does recanalize large vessel occlusion, but nowhere near as good as thrombectomy. But recanalization rate is pretty good for TPA, but it's far inferior to thrombectomy. So that's why if you look at the NINS trial, ECAS trial, they did have patients with large vessel occlusion. We don't know who they were, but someone would have benefit from alteplase or TPA. So TPA does work, but not very good. So therefore, now with thrombectomy available, you will go straight to thrombectomy with TPA or without TPA. But you won't not give thrombectomy patients who are eligible, because it's so much more powerful thrombectomy.
Thank you. I hope you didn't mind me asking you a question on prophylactic secondary prophylaxis of stroke care. So what is the recommended antiplatelet for secondary prevention after ischemic stroke? Clopidogrel alone or dual antiplatelets?
Well, at the moment, if you look at the clinical trial data, if for TIA or minor stroke, it's dual antiplatelets for the first 21 days, and then followed by a single antiplatelet. That's in the guidelines. So basically, dual antiplatelet for a short time, and then a single antiplatelet afterwards. So that's usually, if you look at the Australian guideline, that's what it is. Yes, in the Stroke Foundation. So yeah, short-term dual antiplatelet, and then long-term single antiplatelet.
One more question from Henry. So you touched upon very briefly on the topic of neuroprotection.
Yes.
And this is something I think that has been studied for many, many years, at least 3-4 decades, I think, and always has shown promise in animal models from the earlier studies, like things like magnesium, citicoline, etc., down to the newer molecules. But none of the human trials have shown any benefit. Why do you think that is the case?
Thank you for the excellent question, because I'm personally interested, because I'm actually running my phase 2 embryonic stem cell acute stroke trials and neuroprotection too. I think there are many, many factors. Number one, I think that if so-called neuroprotections, there are so many targets. And most of the drugs we used in the past were basically single or dual targets. We're actually not targeting a whole lot of ischemic cascade or inflammation cascade pathway. What we now need are drugs or chemicals that target multiple pathways. And number two, the animal model may not be correct. If you use all these animal models, particularly smaller animals, their circulations in influx size is very different to human. So that translation from a not perfect animal model to a human model, that's where the problem is. And the third thing I think is it's more about immunomodulation. So if I give an example, my trial using human embryonic epithelial stem cells, the cell actually doesn't go too much to the brain. It actually goes to the spleen and the lymphoid tissues. What it does is shut down the immune system in a multiple pathway fashion. So therefore, rather than like minocyclines and targeting one or two pathways, shutting down the whole immune system actually target multiple pathways. And that's why also MASTER is another stem cell trial looking at the same thing. So I think what we have done wrong, not well in the past, was not the right model, single pathways, and not actually enough immunomodulation effect. So I think we just have to target the immunomodulation stronger. Well, I'm very happy to collaborate in the future if you're interested.
Thank you, Professor Ma, once again for that excellent talk. And now let me hand over to Dr. Niroshan Lukunarangoda for the concluding remarks.
Yeah, so I guess one last thing that for anything, you can refer back to the Australian National Foundation Stroke Guidelines and the American Guidelines. A lot of my information from there, like from antiplatelets, from the thrombolysis, all from there. But I think next year or the year after, if I get an opportunity to say again, I think the data will change again too.
On behalf of Ceylon College of Physicians, I would like to thank Professor Ma for your very enlightening lecture on this very important topic. It was really helpful. I hope you will continue your helping hand to Sri Lanka in future as well. Thank you, sir. I
Thanks
thank
for the invitation.
I thank Association of Sri Lankan Neurologists for collaborating with Ceylon College of Physicians for this month's program. Especially, I'm grateful to Professor Uday Ranawaka for organizing this lecture. Thank you, sir. And also a special thanks should go to Dr. Kumarangi Vithanage for her conducting this question and answer session. I should also mention Mr. Nalina and team for technical support. And finally, I thank all of our online participants for your active participation despite your busy schedule. Have a nice day. Thank you.